Hi there, and thank you for joining me today. I apologize for the delay. We've had some crazy weather here in Colorado, and the internet's been a little wacky today. So thank you for being patient with me. Today I'm going to talk about women's health and hormones. So this will include PMS, menopause, and different thyroid conditions. So just to give a disclaimer, I'm not giving any medical advice to anyone, and please, if you are dealing with any of the conditions that I'm talking about, be sure to see a doctor before trying any type of treatment. So this is a little about who I am. My name is Katie Takacs, and I graduated from Western Michigan University. I obtained my Doctor of Chiropractic degree from Palmer College of Chiropractic in Port Orange, Florida. While I was in school, I completed my diplomate of the American Board of Chiropractic Internists and also my diplomate of the American Board of Clinical Nutrition. I am pending on both of those diplomates. I'll be taking those boards in the fall. So most of my practice is as a functional medicine doctor. That's what the majority of my patients I see are. I do see chiropractic patients, but the majority of my practice is kind of similar to the cases that we're about to get into. So a good place to get started would be talking about some of these conditions. So premenstrual syndrome. Over 90% of women say that they get premenstrual symptoms. This includes bloating, headaches, and moodiness. These are some of the more common things I'll hear. I have awful cravings. All of my friends have the same complaints, so this must be normal. Or I'm unable to go to work or school due to my symptoms. It's very common. I hear a lot of these complaints from women. Menopause. In 2015, 50% of U.S. women are menopausal. By 2020, it's estimated that 45 million women will be over 65. So that's why it's important to know how to address these concerns that women may have, since the number of them is continuing to increase. 80% of menopausal women report concerns of decreased sexual satisfaction, and a lot of them are unhappy with their sex lives. So we'll hear, I have no sex drive, sex is the last thing that I want to do, it's painful, all sorts of different complaints that we'll hear. Thyroid disorders. More than 12% of the U.S. population will develop a thyroid condition in their lifetime. That is 20 million Americans who have some sort of thyroid disease. Women are 5 to 8 times more likely, and 1 in 8 women will develop a thyroid disorder during her lifetime. There's a lot of research coming out that when women are pregnant and they have undiagnosed or inadequately treated hypothyroidism, they have an increased risk of miscarriage, preterm delivery, and developmental problems in their children. We're actually seeing that women that have thyroid disorders during pregnancy, some of them their children have a higher chance of developing conditions like ADHD. So it's very important to be treating these conditions with women as well as supporting them through their pregnancy. So before I get into what these different conditions are, I'd like to explain what hormones are. What is a hormone? A hormone is a chemical released by a cell, gland, or an organ in one part of the body that sends out messages that affect cells in other part of the organism. So how does this work in terms of sex hormones? The brain talks to the gonads via FSH and LH. Our gonads are our sex organs. The messengers from the gonads talk to the cells. Here are some of the messengers: estrogen, progesterone, testosterone, DHEA, and androstenedione. The normal menstrual cycle includes the pituitary gland releasing FSH and LH. FSH is responsible for the maturation of the egg within the follicle during the first phase, and as estrogen levels rise high enough, this is what releases LH. LH is responsible for initiating ovulation or the release of the fully developed egg. After ovulation, the eggless follicle is transformed into what's called the corpus luteum, and this is what primarily secretes progesterone and estrogen, and this is what helps to support a fertilized egg in the uterine lining. If fertilization doesn't occur, the corpus luteum is shedded, and this is what the menstruation is. This is the bleeding that we see occur. A typical cycle is completed in about a month, with the first day of bleeding marking the first day of the period. So this is something that I try to educate a lot of my female patients in office, is knowing when their period starts and how to actually keep track of it. So the first day of bleeding is what's signaling the first day of their period. The cycle is divided into 3 different phases in order of how they occur: the follicular phase, the luteal phase, and the ovulatory phase. So as you can see, looking at some of these graphs, you can see at the bottom of the table the number of days that pass, and as you follow the different categories up the side of the graph, it shows different hormones that we're looking at. So the one on the bottom, the uterine cycle, that's showing the thickening and the thinning of the uterine lining. The second box from above that are ovarian hormones, so that's looking at estrogen and progesterone. Above that are our pituitary hormones, and those are LH and FSH. And body temperature is something that is typically observed when a female is trying to become pregnant. There'll be a spike in body temperature on the day of ovulation. So this is one thing that I'll also have with my female patients if they're trying to get pregnant. I tell them to monitor their body temperature on every day. So what effect does birth control have on the female cycle? A lot of times as females, we think, oh, birth control really doesn't have an effect on me. It makes me have regular periods, makes my acne go away, it makes my cramping go away. But what is actually happening during the cycle? So any type of birth control, whether it's the ring, pill, or an implant, they stop the FSH and the LH surge from the pituitary gland. So what this does is prevents a rise in estrogen and ovulation, which is progesterone production. So if you can see in that graph, the green is estrogen and the red is progesterone. As you can see, if I look at the previous slide where there's nice peaks and there's highs and lows of each of these hormones, you can see the increase in estrogen and the increase in progesterone. If we look at someone that's on the pill, these hormones kind of tend to stay in the same range the entire month. So if you hormone test a woman when she's on the pill, her estrogen and progesterone should be quite low, as we can see in this picture. That means that the pill is doing its job and she's likely not going to become pregnant. Thyroid function. The pituitary gland also has a major control over our thyroid. It is regulated by the hypothalamus, an area of the brain. This produces TSH, which is thyroid stimulating hormone releasing hormone, so TRH. The thyroid gland is under control of the pituitary gland, and when thyroid levels drop, or what you'll commonly hear is T3 and T4, the pituitary gland will produce more TSH. This then stimulates the thyroid to increase the amount of T3 and T4 that it's producing, and the pituitary gland will get signals from that and know that it shouldn't secrete any more TSH. So you can kind of see the picture on the right kind of depicts the cycle of that occurring. Hormone testing. So one thing that I definitely look at in my patients a lot are hormones, as you're going to see more of as I get further into this presentation. Traditional medicine, you'll sometimes get some of these hormones. I've had women come into me and say that they've been diagnosed with certain conditions with 1 or 2 hormones that have been looked at. So I like looking at all of these because it shows me not only what the female sex hormones look like in terms of progesterone and estrogen, but also some things called testosterone and DHEA. These are more of the times considered hormones that we think of when we think of men, but we actually all have the same hormones. It's how we keep them regulated that kind of helps to balance us out. Receptors. So I think understanding how receptors work is important, and understanding how hormones function within the body. All hormones need a receptor that work like a locking key in order for it to fit properly. Just like sometimes you can have a key that might fit in a lock and it doesn't really do anything to the door even though it fits. That would kind of be an example of this. We want a key that's going to fit in the lock and unlock the door. The slippery slope of hormone replacement. So what ends up happening is with little available hormone, receptors move to the surface of the cell and try and grab more hormone. So if you look at the picture on the left, it shows upregulation. There's different hormone receptors. Those are the purple boxes on the outside of the yellow cell. When there's not enough, they'll send more of those receptors out to the edges to try and bring in more hormone. What ends up happening is hormones, or during hormone replacement therapy, too much hormones are being pushed into the body and pushed into the cells. So when there's too much hormone, the opposite happens and the receptors move inward because they don't want any more of these hormones, which then you kind of have this up and down, back and forth of too many hormones, too little hormones, too many hormones, too little hormones, etc. This scenario causes dependency on the hormone, kind of similar to what we would see in people coming off of an antidepressant. So I think this is an example everyone's heard of before. When you come off an antidepressant, it isn't something that you should stop immediately. It's something that you need to be, you have to come off slowly and, of course, under the supervision of a doctor. The entire hormone axis. So testing the hormones is not enough. You can still have things going on besides low hormones or high hormones. This could include poor clearance, uncoupling of central nervous system and its organs, enterohepatic recirculation. So there's a lot of things that can still affect our overall function of the body. This is why I'm not a huge fan of protocols, because I believe that each patient is unique and each patient should be treated differently because of that. Hormones. So getting into hormones a little bit more here. We're going a little more in depth. So the first one I'm going to talk about is estrogen. It's the primary female sex hormone, and all hormones are built from cholesterol. So everything in our body, or every hormone in our body, starts from cholesterol. This is why it's important to monitor our cholesterol levels through our life as well. These can be produced by the liver, the adrenal glands, and the breast tissue. They're mainly produced by the ovaries and during pregnancy by the placenta. FSH is secreted by the pituitary to stimulate the production of estrogen, if you didn't really remember from before. We also have 3 different types of estrogen. We have E1, E2, and E3. Which one dominates is kind of changes throughout our life. So E1 is more dominant in menopause. So women that have been through their sexual life already and then are entering menopause, typically E1 will be higher in them. E2 is something that is more dominant in women that are menstruating. And E3 is estrogen that is the most dominant during pregnancy. Negative effects of estrogen. So you can see there's quite a few things on this list. Some of the ones I focus on are increased body fat, increased salt and fluid retention, increased blood clotting. So we'll have a lot of women report they have heavy clots during their cycles sometimes. They have an increased risk of endometrial cancer, and it can also impair blood sugar control. So you can kind of read the rest of these things on here, but another issue that it has when we talk about the thyroid in a little bit is that it can interfere with the thyroid hormone. But estrogen is not all bad. There are a lot of positive things to estrogen. It is neuroprotective and cardioprotective. It affects our dopamine and serotonin levels, which are neurotransmitters that kind of function in our feel good or that makes us feel happy. It can influence sexual function along with drive and motivation, and it can promote lubrication for sexual activity. So sometimes low estrogen women may report with vaginal dryness during intercourse. What we need estrogen for. So estrogen is good and bad. We just want to have the perfect balance of it. So these are some of the things that are really important for estrogen. It promotes formation of female sex characteristics. It can increase HDL and decrease LDLs. It helps to regulate melanin. Melanin is the pigment in our skin. Sometimes you'll see people that have like little brown spots on their forehead or on other parts of their skin. If that's seen in women, it's usually due to some sort of melanin problem, which is likely suggestive of high estrogen. It can also, like I said, it can increase HDL and decrease LDLs. HDLs are going to be your good fats or your happy fats with an H. That's what I usually tell people to help them remember. And LDLs would be your bad fats. So estrogen has a lot of really great benefits to it when we don't have too much or too little of it. Signs of estrogen dominance. So these are the most common things I hear from my patients. I get a lot of cramps, like when I was younger. I don't have my period, or my periods are irregular. I have very tender breasts around my period. I have PMS symptoms. I'm tired all the time. I have lots of clots during my period. So these are all examples of estrogen dominance. High estrogen also blocks thyroid function. Estrogen dominance can increase the sex hormone binding globulin, and this binds to all hormones, including testosterone. So it can end up disrupting the ability of the thyroid hormones to bind properly. The next hormone I'm going to be talking about is progesterone. This is formed, again, by cholesterol and is made within the corpus luteum. This is sometimes referred to as the pregnancy hormone. So a lot of times we'll hear women say that they feel absolutely amazing during their pregnancy. It's the best they've ever felt. They have this pregnancy glow, and that is due to progesterone. Progesterone makes them feel really happy. This is also why following pregnancy, it's more common to see postpartum depression in women, because they're so used to having their progesterone levels so high that once they deliver their baby and the body is starting to try and regulate itself again, progesterone drops too quickly, and then these women suffer with postpartum depression. Another point that I like to make is progestins are what is used in contraception. They aren't the same as progesterone. So progestins are a synthetic form of progesterone. The problem with these is they do not have they're not specific to binding to progesterone receptors. They can actually bind to estrogen receptors. They can bind to testosterone receptors. So taking the birth control doesn't always necessarily mean that the hormones are going to be going where they're supposed to be going. That's why sometimes when women come off of birth control, they tend to have a lot of problems once they come off of it. Progesterone is also neuroprotective. This isn't really getting into a whole lot of what we're talking about today, but I like to base a lot of my treatments and a lot of my just talks on research that I've read. So I just thought these were a couple of interesting studies where they used progesterone to treat after traumatic brain injuries, and it actually showed decrease in inflammatory cytokines following the administration of the progesterone. The next hormone we're going to be talking about is DHEA. So if you look to the left, there's a picture where it shows the full flow chart of the development of hormones. As you can see on the top left, there's cholesterol, and that creates all of the hormones, kind of like I was describing. So DHEA is the most abundant steroid hormone in the body. It's produced by the adrenal glands, DHEA, and sex organs, and it has an antioxidant and anti-aging effect. Testosterone is the main steroid found in males, but also present in females. It's cardioprotective, preserves sexual function, and kind of on a men's health note, it protects prostatic hyperplasia in males. The thyroid. So the thyroid influences metabolic rate and protein synthesis. T3 and T4, those are the thyroid hormones that we hear talked about the most. They're created from iodine and tyrosine. They're the only cells in the body that can absorb iodine. When the thyroid hormone also produces calcitonin, which plays a role in regulating calcium. Every cell in the body depends on the thyroid for regulation of their metabolism. That's why it's so important for this organ to be functioning properly. Free thyroxine, which is also known as free T4. This is secreted by the thyroid gland and is then converted into triiodothyronine, and which is T3 in peripheral tissues. So TSH is released from the pituitary gland to stimulate the thyroid. The thyroid then releases T3, and it gets converted into T4 in peripheral tissues. So these tissues would be the liver, the GI tract, elsewhere in the body besides the thyroid. It's considered the storage and transport form of the thyroid hormone. By itself, it has a weak biological activity within the cell. So free T3 is going to be the more potent thyroid hormone, which is this one right here. Your thyroid also sits kind of on the front of your throat. If you feel the trachea, if you kind of feel the front of your throat, you'll feel a bunch of rings. If you move up a little bit, you'll kind of feel a large lump in your throat. That is going to be your thyroid gland. So T3 is 3 to 4 times more potent than T4, and it gives us a more accurate picture of thyroid function and conversion than total T3. Thyroid stimulating hormone. So as this picture is kind of a basic cartoon, but it gives you a good idea of what we're looking at here. The hypothalamus is what releases TRH. That's what stimulates the pituitary gland, which releases TSH. The pituitary gland then sends a signal, or the TSH from the pituitary gland will stimulate the thyroid, and that will release our T3 and T4. But because abnormal values cannot be considered absolute evidence of thyroid disease, we also have to assume that in the opposite direction, that normal TSH values don't necessarily mean a fully functional thyroid. That's why it's important to look at an entire panel. Reverse T3. So this is one that people don't typically have ordered in traditional labs. This is something that a lot of my patients have never heard of before, but I think it's very clinically relevant, and I use it on all of my thyroid testing. This is produced in peripheral tissues, the liver and intestinal epithelial cells. So reverse T3. So when T4 is converted into T3, it can either be converted into the active form, which would be free T3, or the inactive form, which is reverse T3. So that's where these two different T3s are coming from. It acts as an antagonist to thyroid function. So what happens is reverse T3 and free T3 can occupy the same binding site within the thyroid. What ends up happening is if there's too much T3, it actually has a higher affinity to the binding sites than T3 would. So if you think about it, this inactive hormone, if there's more of this inactive hormone than the active hormone, then there's going to be a lot less function. Also something to consider for those of you that are doctors, when you look at the free T3 and reverse T3 ratio, this can help give you more insight as to what the body is doing with T4 to make sure that it's being converted properly, whether it's making too much T3 or if it's making too much reverse T3. Low conversion ratio means that tissues are preferring a reverse T3 conversion over a free T3, meaning it kind of shows up as less or a lower functioning thyroid. One note to make on that is to make sure that you check your units before converting. So if that's something that you have questions on, just feel free to ask me or send me an email. I can help you interpret these labs. Thyroid antibodies. So this is another part of the thyroid panel that I look at, and this includes anti-TPO and anti-thyroglobulin. These tests are necessary for ruling out autoimmunity to the thyroid. So the two autoimmune diseases of the thyroid include Graves' disease, which you can see the picture on the left, and Hashimoto's, which is the picture on the right. So people that have Graves' disease typically feel more anxious. They will sometimes have these bulging eyes that you can see in the picture. That's not always a distinct clinical, it's not always very distinct in people. They usually have anxiety. They feel like their heart's racing a lot, and they may have a goiter present. People that suffer from Hashimoto's disease typically complain of weight gain or inability to lose weight, constipation, and may have brain fog, depression, all sorts of different things. And these are just a few examples of some of the things that may be occurring in these people. So I like to run this test because when I look at the thyroid testing overall, it's important to know, is this a hypothyroid condition that is also an autoimmune condition? It's very important to rule these things out when proceeding forward in care. So what is the cause of all of this dysfunction? Poor food choices. Excess sugar can lead to insulin resistance, which can disrupt hormones. Ubiquitous use of birth control during maturing age, medications, excessive stress and stressors. And I guess I thought that stress was very important because I added it to the list again. So lots of stress on here can cause dysfunction. Irregularities in hormones. So PMS, this is one of the most common things I think women tend to experience at some point in their life. And if you haven't, then that's awesome. I think the picture on the right is pretty funny. I'm fine, I hate you, I love you, I want ice cream, come here, get away, oranges. So I think that's pretty accurate. I think it's kind of funny. It's actually not a normal part of the cycle. These symptoms usually show up a week or two before menstruation. And it's classified according to symptoms: anxiety, carbohydrate cravings, depression, and mood fluctuations. PMS causes. So I like this picture because I think it gives a really good depiction of what our hormones like, if you kind of remember what it looked like from before. If you don't, then I'm going to explain kind of what this looks like. The blue line represents estrogen, normal estrogen, and the solid gray line represents normal progesterone. That is what your hormones should look like when you're going through your menstrual cycle. The dotted gray line is low progesterone. So what ends up happening is PMS is typically caused by an elevated estrogen to progesterone ratio. This means either estrogen can be very elevated, or like we see in the picture, progesterone may be too low, which still suggests an estrogen dominance. Even though the estrogen is within the normal range, as you can see, that's not what changes. It's the progesterone that's too low, which is causing this estrogen dominance kind of to occur. This can also be due to impaired liver function or slow functioning of the liver. reduce serotonin production. So serotonin is kind of what makes us feel happier. When there's decreased levels of that, that can cause depression, anxiety, kind of the symptoms that come along with PMS at times. Decreased action of B vitamins and increased production of aldosterone. So therapies that we may give to women that have PMS would be to enhance their liver detoxification, different B vitamins, including choline, folic acid, B12, definitely decreasing sugars and refined carbs. This helps to regulate blood sugar. So even though you may be craving sugars during your period, it's actually going to create the problem worse by disrupting the effectiveness of how your body's regulating blood sugar. We may do some progesterone therapy if it's indicated from testing. We would consider low thyroid function and a few of other supplements that we may. Essential fatty acids are super anti-inflammatory to the body. They're very great, and they can help reduce pain. Menopause. So changes that occur from menopause, women actually go through two different phases as this is happening. As you can see, the graph on the left shows our estrogen levels as we go throughout our life. So you can see it increases around puberty. It stays pretty elevated through our sexual maturity or our reproductive years. And then estrogen levels will start to drop as we enter menopause. So perimenopause is the slow decline of estrogen from the ovaries. This usually is about 4 years, but can last up to 10. Menopause is the diagnosis of 6 to 12 months without a period. Few follicles, so this results in estrogen and progesterone, decreases in those hormones, and then decreased estrogen triggers increased release of FSH and LH from the pituitary. So as you can see, estrogen levels start to drop around the age of 40, kind of into the late 30s, and then they continue to drop throughout. Menopause symptoms. So I myself haven't been through menopause yet, but I've been told that the picture on the right is pretty accurate. Menopause, it's like being a testy human volcano with PMS, only sweat pours out instead of hot lava, but people still run for you in fear of their lives. So I thought that was pretty funny. And some of the most common symptoms that I'll hear from my patients will be breast tenderness, decreased libido, fatigue, vaginal dryness or painful sex, urinary urgency, mood swings, difficulty sleeping, and I think the number one is hot flashes. So evidence actually suggests that a decline in estrogen levels in menopause is associated with an increased risk of inflammatory cytokines. What this is saying is that inflammation may kind of depend on the cells that are present. So what we like to work towards is, rather than waiting until a woman gets to menopause to start treating her, we like to try and treat her as she's transitioning through the phase. That would be decreasing inflammation, making sure that her hormone levels are kind of going through the proper process that they're supposed to be, all sorts of different things that we can do. But prevention is key, and this is the best way, I think, to treat disease before it occurs. So therapies to treating menopause would be to increase serotonin and dopamine, establish proper gut flora, and increase prebiotics, balancing the hormones. So typically in menopause, what ends up happening is their estrogen levels actually drop too low. So it's something that we deal with our whole life, where we have too much estrogen, and then as we enter our menopausal years, there ends up being too little estrogen. So sometimes we can administer different estrogens or different supplements or nutraceuticals that can help stimulate more estrogen to be produced by the body. We can also supplement with anti-inflammatories. This will decrease pain, and then potentially natural progesterone cream. So like I said earlier, each patient is going to be different. There's not one hormone that there's not one supplement that I specifically give to my patients with menopause, or one therapy that I give to my patients with PMS. They're all different. So it's very important to consider the entire patient case, as well as things outside of the hormone complaints. I do a lot of gut support with my patients. I believe that has a huge impact on their overall health. So the next thing that we're looking at is thyroid dysfunction. So this chart kind of just gives you a quick look at what some of these tests usually mean. This by no means should be used to diagnose anything, but more to kind of give you an idea of what you're looking at when you look at these lab values. So TSH, if it's elevated, can indicate hypothyroidism. If it's low, it can indicate hyperthyroidism. And then you can kind of follow that down: free T3, free T4, reverse T3, and anti-TPO. So the reverse T3 can actually indicate hyperthyroidism or hypothyroidism. In order for it to indicate hyperthyroidism, all of the other thyroid hormones should be elevated. So that would include TSH also being elevated. Like I said, this isn't kind of the end-all be-all on diagnosis, but this kind of gives you a quick look at different things to consider. This is actually a patient of mine that had functional hypothyroidism. So she didn't have Hashimoto's, but I'm going to get into the testing in just a second. This is a 27-year-old female. She presented with the inability to lose weight. And also her biggest complaint was that she only moves her bowels 1 to 2 times per week. That was her #1 complaint. She follows the paleo diet and she exercises daily. So she's very active. She follows a very clean diet, and her biggest complaint was that she's not moving her bowels enough. So I ran a thyroid test on her. And as you look at this, you can kind of follow the chart down and you can see the values next to the reference ranges. So the reference ranges that I use in my office are a bit narrower than what we would use in, or that what you would see on a traditional lab. The reason is because we believe in my practice that people function the best when they're within these ranges. That's why we keep them a little bit narrower. So as you can see, I highlighted the things that were out of range. She had high TSH, high free T3, very high reverse T3, and her reverse T3 ratio was at 12.7. We like to see that above 20. As you can see, I also looked at the autoimmune profiles for thyroid, and neither of those were elevated, so we were able to roll out Hashimoto's. So what we did next was daily fiber, MCT oil, a supplement called GTA Forte 2. This is from one of the companies that I really like. This helps to stimulate the thyroid, and then also S. boulardii. After following up with her a few months later, the patient is currently moving her bowels on a daily basis, and she said that she feels much better because of this. So this next case study I have is another patient of mine. I always think it's kind of interesting to share cases with you guys. It kind of helps tie everything together from what I've been talking about. So this patient of mine, she's 4 years old. She has a history of endometriosis that she's previously had surgery for. She has constant pain, headaches, low libido, fatigue, painful intercourse, low energy, heavy irregular periods, history of birth control use for 10 plus years, cystic painful breasts, and night sweats and hot flashes. So her pain is kind of just her entire abdominal area. So I ordered some testing on her called the Dutch test, CMP, CBC, iron panel, and the thyroid panel. So her thyroid came back with low T3, low T4, and elevated TPO, as you can see, on a range of